of a high-level overview and to sort of answer the question that you posed, which is why transplant or why not transplant, and what are the barriers for transplant and other immunotherapies for Erdheim-Chester. So by the end of my talk, I hope that you can understand the therapeutic principles of a bone marrow transplant, list the potential advantages and disadvantages of a novel type of immunotherapy called chimeric antigen receptor T-cell therapy or CAR T-cell therapy, the goal of which is to obtain targeted immune reactivity without long-term side effects, to describe an approach to designing such a therapy and what are the barriers there and why research is so important to develop these types of therapies, and then to identify some of the risks and challenges for the application of CAR T-cell therapy to Erdheim-Chester and other histiocytic diseases. So this is a diagram that has undergone evolution over the past 20 years, 25 years, but it's called the hallmarks of cancer. And these are sort of the central features of cancer, and some of which are unique to ECD. So cancers in general require self-sustaining signals, including mechanisms to evade targeting. Otherwise, we would cure them with our first attempt, and we all know that that's very rarely the case. Erdheim-Chester is both pro-inflammatory and neoplastic. That is, that there are inflammatory signals and there are growth signals that are that emanate from the cells themselves. And these signals acquire cellular changes that sustain survival and proliferation, avoid destruction, activate dissemination so that the cancer spreads, the ECD cells spread to the other organs and invade tissues. They evade local signals that try and combat these growths so that they're they can, or that this is a reason why they do damage, and that, of course, they resist the death that we try to impose upon them through chemotherapy and other targeted therapies. And finally, the ECD cells change over time. So there's genomic instability that the mutations can change and evolve. Many of you are familiar with various types and approaches to therapy, and this is just sort of a high-level overview. There's hormonal therapy, which blocks some of the growth signals. You can try and cut out some of these lesions with surgery, although for a cancer that's widely disseminated, that's rarely effective. I'm going to skip over hematopoietic cell transplant for the moment because I'm going to come back to it. Of course, we can use chemotherapy to try and kill those cells selectively through the application of carefully titrated toxins, essentially. We can try and evolve personalized therapy where we inhibit the specific mutations that cause the growth of those cells, as we heard from our first speaker, in the BRAF mutation, which many of you have experienced. Radiation therapy or radiotherapy, where we try and irradiate the cells to induce selective death. And immunotherapy, where we try and induce immune reaction against those cells. So this is an example of the response that we can see on a PET scan to cladribine, which is a chemotherapy. You can see at the beginning, there's a lesion within the spine there on the top and in the aorta. After the therapy, that lesion has gone away there on the left side, and then on the right side, you can see that there's a lesion in the neck of that patient, again, which has improved following chemotherapy. But of course, these therapies can fail patients. So after the application of the chemotherapy, the lesions can get better, but of course, then they can get worse again. And so oftentimes what happens is that there's incomplete eradication of tumor cells. The ECD cells can alter their physiology, or they can become resistant to those chemotherapies. And so that implies that maybe we just need to give more chemotherapy, but of course that has increased toxicity as well. So finding that right balance can be a challenge. Now, in an extreme case, we can give effectively lethal doses of chemotherapy. So we can give the maximum amount of chemotherapy that we could give and then push that envelope even farther. And the site of first irreversible toxicity for many of these chemotherapies is the bone marrow, the blood-forming cells in the body, which potentially could be overcome if we could simply replace those cells. So think about that for a moment. We're going to bring you to the brink of death with high doses of chemotherapy, and then replace the cells that are the most sensitive to that chemotherapy, namely the cells within the bone marrow that form the blood. Now, you've seen this image before, but it turns out that those same cells within the bone marrow are the site of origin of many of the ECD cells that cause this disease. So through research done by some of you in this room, You've identified the presence of this BRAF mutation within the blood-forming stem cells of the bone marrow. So maybe we could use this technology to eradicate the bone marrow from which the ECD cells derive, and then replace it with fresh bone marrow after such high doses of chemotherapy. That's the concept of the bone marrow transplant. In the graph on the right, in B, it shows the proportion of cells that are the ECD progenitors, or who harbor that BRAF V600E mutation. You can see it's a very small proportion. So we're using a sledgehammer to get rid of 0.1%, 0.15% of the cells within the bone marrow. So that's the goal here. Well, could this work? Well, the idea sort of originated within the 1940s, where radiation effects were being described in preparation for the Manhattan Project. This is a picture of Leon Jacobson, who first described the idea that one could shield certain parts of the body from radiation, and that the cells within those parts of the body that were shielded could restore bone marrow function. And initially, those were the hind limbs of mice or the spleen of mice, and that principle was used to identify many of the blood-forming cells within the bone marrow, and then to isolate those cells from donor mice and transplant them into otherwise lethally irradiated recipient mice and restore hematopoiesis, or the formation of blood. So stem cell rescue could boost the tolerable doses of radiation or chemotherapy. And then that sort of raises the question, could high doses of radiation or chemotherapy be combined to eradicate ECD progenitor cells or other cancer cells, and could this be applied therapeutically? Well, that idea has been tried, but not very often and with limited success. So this is a slide that, sorry, that got cut off there at the bottom, but this is from about 2006, where a report of about 6 patients with Langerhans cell histiocytosis, or ECD, underwent autologous transplant. And you can see that the results, I would say, are middling at best. So unfortunately, good in theory, maybe not so great in practice. 6 cases, 5 with ECD, 1 patient with Langerhans cell but non-active disease. All 5 patients had regressing lesions, and about 4 of the 6 were better after the transplant. Unfortunately, 3 of the patients survived less than 14 months after this therapy. And 1 patient with Langerhans cell survived without relapse at almost 5.5 years or so. And 2 patients survived long-term. So I would say that some, guarded optimism is maybe the appropriate approach here, but prime time therapy or early therapy, this is not, because of the side effects. Okay, so what if we could replace the existing hematopoietic system with a new system eradicating ECD? Well, so this is the idea. So could we identify a donor who is a tissue match, give high doses of chemotherapy, and then use somebody else's bone marrow to replace the functioning bone marrow of the patient? Why would that be helpful? Well, that induces a state of immune surveillance, where these where the new immune cells from the transplanted bone marrow interrogate the cells of the recipient. And they do so through specific interactions of the T cell receptor and a protein on the recipient cells called major histocompatibility complex, or MHC. The other word for that is HLA, or human leukocyte antigen. So that interaction is how a T cell decides whether to kill the recipient or the target cell or not. That has the benefit of eradicating tumor cells. It has the disadvantage of reacting against all the other cells in your body. And that's what GVHD, or graft versus host disease, is. That's a lifelong diagnosis. It persists, and it can cause inflammation in any part of the body: the skin, the lungs, the gut, the eyes, principally. So that's a trade-off. You gain graft versus tumor effect, but you also gain graft versus host disease. And modulating those 2 things is the task of the transplantation physician, to try and optimize that ratio. So there's always activation and deactivating signals. And unfortunately, teasing apart the graft versus host versus graft versus tumor effect has been very challenging. What you can see here is a classic graph where the more graft versus host disease you have, the more graft versus tumor disease you have also. So those 2 things go together. When we did initial bone marrow transplants between twins, there's very little graft versus host disease. Unfortunately, those transplants in the case of leukemia led to frequent relapse. So that was ineffective at gaining graft versus tumor effect. On the other hand, for patients who got both acute and chronic graft versus host disease, their relapses were very rare. So we have not yet been able to tease apart graft versus tumor and graft versus host. Okay, so the bone marrow transplants combine chemotherapy, radiation, and immunotherapy, but again, they are this double-edged sword. Do they work in the case of Langerhans cells? Does the transplant actually replace the cells that we're trying to eradicate? It turns out that it does. If you look at patients who had a bone marrow transplant from a sex mismatched donor, so a man into a woman or a woman into a man, and we look at the genes in the Langerhans cells within the skin of the recipient, it turns out that those cells are from the donor after a period of about 100 days. So if you're a woman, you got a transplant from a man, you can find Y chromosomes in the cells within the skin, the Langerhans cells, and that increases over time. So it does seem, at least theoretically, like a bone marrow transplant could replace those cells, although with a lot of toxicity, as I mentioned before. Okay, so going to CAR T cells. So what is the theory about CAR T cells? So here the idea is we're going to activate the T cells instead of through that T cell receptor MHC interaction through a chimeric antigen, a receptor that we build ourselves. And we're going to compose this receptor with all the parts necessary to recapitulate the activating signals of the T cell receptor. And we do so by stitching together an antibody which binds to a specific target and two intracellular domains, typically one called 4-1BB and CD3 zeta. These are pieces of proteins that activate the T cells in a manner very similar to the manner in which the native T cell receptor activates the T cell. So this provides all the signals that the T cell needs to survive and kill targets when the antibody sticks to its target. So the antibody is the thing that says to what should the T cell react. That question, to what should the T cell react, is actually relatively unknown in the case of ECD. And so that's a key area of research that needs to be better developed. In the case of lymphocytic leukemia or multiple myeloma, other cancers with which you may be familiar, those targets are very well described. CD19, BCMA, these are the things that the antibodies target in those diseases. But in the case of ECD, it's not really known what the optimal target is. Okay, so what are the steps? So first, we need to identify the CAR target, as I mentioned. We need to consider safety. What else expresses that antigen that we are targeting? So in the case of CD19, that target is actually fairly restricted into B cells and other cells that if you get rid of them because of with the CAR therapy, it doesn't really matter. In the case of ECD, we don't really have a great CAR target. Then we need to identify an antibody that sticks to that cell, stitch it together into the chimeric antigen receptor, see if the chimeric antigen receptor does the job in the T cell by manufacturing small scale, lots of these CARs, testing them in the lab before giving them to patients. The principal job of the CAR cell biologist here is to find or to design this gene for the CAR, this synthetic gene that we stitch together. And so, as I mentioned, identifying this antigen receptor domain or the antibody that sticks to the target is the key thing, and then figuring out how to stitch it together with the other T cell activating components are really the job of the synthetic biologist here. Following that, we need to grow these cells in the lab and test whether they kill the target cells prior to infusing them in the patient. Unfortunately, right now, this is very expensive work. It's challenging to make these genes. It's challenging to make the viruses that take these genes and put them into the cells. So this is something that that needs research funding to pursue. This is an example of one of the potential targets for ECD, and that's CCAM6. Now, you can see here that there are maps of antigens that are expressed by ECD cells. doesn't express. So on the top, on the right-hand side of things are, in this case, LCH lesions. And the brown is the reaction of the antibody with a coloring chemical. So when it's brown, that means that the antibody stuck to those cells. And you can see that they express a lot of CEACAM6. That's top second from the left. You can see that they don't express very much CTLA4. They express a lot of HLA-D and not so much CD33, for example. A lot of, this is an LCH lesion, so a lot of CD207 that would be missing on an ECD lesion. But anyways, you get the idea. Thanks to research that you and others have supported, there are now large maps of what normal tissues look like. And so in this case, we know, for example, that CEACAM6 is expressed on the nasopharynx and the bronchus and in the lung, as well as in the gut and in the appendix. So we could anticipate that a CAR that was designed to target CEACAM6 would react against those tissues as well. So the search continues to find the optimal target for an ECD immunotherapy. And at the moment, that is why I would say that CAR cell technology is really on the back burner compared to these targeted therapies. Okay, so my conclusions are that allogeneic transplant is theoretically curative, but very risky. I think the last CIBMTR survey that I saw had about 90 reported transplants for mostly for LCH and mostly in children. The autologous transplant is only really partially effective. There is one case where patients had underwent a single autologous transplant. It didn't work, and then the patient underwent a second autologous transplant, one after another. That worked a little bit better, but obviously it's a lot to undertake. I would say that in general, compared to other diseases, allogeneic transplant has not been well studied for patients with ECD. And so that's really the call for additional research and cooperation among sites, and why the societies like this one are so important, because they can engender joint cooperative protocols that can overcome some of the challenges of rare diseases. And so please email me if I can be helpful. Paul knows where to find me. So thanks so much. And I'm happy to take some questions.
We have time for thank you for that. I'm just curious, has there been any anyone done the CAR T cell therapy on any ECD patients to date?
I don't believe so. Not that I am aware of.
How do we get the additional funding? You said you need research funding for this, and how do we get the research funding for this?
Well, I think interested parties need to, apply. I think that there are certainly national funding organizations like NIH and NCI that can fund some of these studies. In the case of CAR cell therapies, one challenge is that a lot of that work is funded by pharmaceutical companies. And with a rare disease, the return on investment may not be obvious for them. So that's why, patient advocacy is really important. I think the other thing is to figure out, are there areas of overlap? So are there cases where research into ECD applies to other more common scenarios? So, creating win-win situations is also really important. And of course, research uncovers those situations. You don't necessarily know what they are when you're starting out. So that's my response to that.